So the common complications of infective endocarditis are valvular destruction because of releasing of toxins by the causative organism, and embolic episodes like septic emboli that can lead to CVA or any organ injury, and valvular regurgitation lesions because of the vegetations over the valve mobility will be restricted. It cannot get approximated and opposed easily, so it can lead to regurgitative lesions and extension of the infection into the myocardium, and this can also lead to abscess formation. That is, a myocardial abscess can also occur, and periannular abscess can also occur here. And when the infection extends into the myocardium, it can also affect the conduction system of the heart and results in the conduction system abnormalities, and arrhythmias can also occur. And this failure, valvular pathology, can result in heart failure. So, antibiotic prophylaxis in case of infective endocarditis. If a patient who are supposed to go for a procedure, a dental procedure even, he should go for an antibiotic prophylaxis. So, what are the indications for antibiotic prophylaxis? Prosthetic cardiac valve is the primary indication. Any patients with a prosthetic cardiac valve should take an antibiotic prophylaxis for sure. Patients who use artificial prosthetic material for cardiac repair, even if the people have not done any replacement, just a repair was done, but with an artificial ring like annuloplasty ring, the patient should take antibiotic prophylaxis. And if there is a history of previous endocarditis, an untreated cyanotic congenital heart disease patient who requires treatment further, untreated case of congenital cyanotic heart disease. The cyanotic heart disease is a more important thing, or a patient who have undergone a bridging therapy like a shunting treatment, like a residual shunt is left for a patient. For example, in case of a patient with tetralogy of Fallot, we usually go for an bridging therapy with the Ballock BT shunting with an artificial prosthetic material or by direct anastomosis. Those patients should also require to take antibiotic prophylaxis. And in case of patients with the VSD closure or ASD closure with the minimal shunting or residual shunting is present, if the residual shunting is present, for sure the patient should go for antibiotic prophylaxis for sure. And post cardiac transplant patient with valvular regurgitation lesion. So the criteria for antibiotic prophylaxis to prevent acute episode of infective endocarditis are prosthetic valve patients with prosthetic valve, replaced valve, patients with valve repair using a artificial prosthetic materials like annuloplasty ring, and patients who had a previous history of infective endocarditis, and in patients who are already known case of cyanotic congenital heart disease not treated, not a definitive procedure is done for that patient. And in cases with surgery done like a VSD closure done or ASD closure done with a residual shunting is there. If residual shunting is there, then we should also go for antibiotic prophylaxis for this patient. In case of post cardiac transplant regurgitation patients, also we should go for antibiotic prophylaxis. So, what is the regimen to be given? When to be given? First thing, it should be given 30 to 60 minutes before the procedure. The antibiotic prophylaxis should be started or should be given at least 30 to 60 minutes before the procedure to be done. Commonly used antibiotic are cefazolin. This is the first generation cephalosporin, and ceftriaxone, third generation cephalosporin, ampicillin, clindamycin, and clarithromycin also can be used. But commonly used drug is ceftriaxone or cefazolin, and the preferred route of administration is IV. IV is the intravenous route, is the preferred route of administration. But in case if it is not possible, amoxicillin and clavulanic acid can be given orally. This amoxiclav can be given as an oral drug for infective endocarditis prophylaxis. Okay, other drugs like cefazolin, zone, ampicillin, clarithromycin, clindamycin or IV drugs. Okay, and preferred route of administration is IV. So coming to the treatment part, the treatment of infective endocarditis is both medical and surgical management. So first we should start with the medical management, that is giving an adequate appropriate antibiotic, followed by surgical eradication of the infective emboli focus. Okay, the focus of infection should be removed by surgery with the antibiotic coverage. First thing to be done is antibiotic coverage, medical management first, followed by surgical intervention. Okay, the duration of antibiotic should be at least 2 to 6 weeks. Considered to be, make it clear, the antibiotic prophylaxis needed is between 2 to 6 weeks. Okay, the treatment should be started with the antibiotic first, and then we should go for surgery. So coming to the treatment's drug of choice. Previously we saw about the drug of choice for prophylactic antibiotics to prevent in acute episode of infective endocarditis. Now we are going for a drug of choice for treatment purpose. Okay, so patient is being received at right now. Right now we don't know what is the blood culture positivity report and what are the drugs that the organism is susceptible to. So we should go with an empirical treatment. Okay, so we should not wait for culture sensitive report. We can start with an empirical treatment. The first line drug for empirical treatment is fluocloxacillin and gentamicin. These are the drug of choice, first line drug of choice for empirical treatment of infective endocarditis. Okay, the benzyl penicillin is the first choice of drug if the streptococcus or enterococcus are susceptible to penicillin. If the streptococcus, enterococcus species are susceptible to penicillin, benzyl penicillin should be given. Okay, so in case of MRSA, that is methicillin resistant staphylococcus aureus, we should go with the vancomycin, higher antibiotic. If the patient is affected by infective endocarditis and the causative organism is resistant, or if the causative organism is a MRSA, that is methicillin resistant staphylococcus aureus, we can go for vancomycin. In case if vancomycin is also resistant, then what you have to do? You can go for teicoplanin, lipopeptide, daptomycin and linezolide. These are the drugs which can be given in case of the organism which are resistant to even vancomycin. So what can be done if the infective endocarditis is because of fungus? First thing, we should do surgical eradication of the foci. Okay, keep it in mind. And then we should go for fluconazole and capsofungin. What is the difference between this fluconazole and capsofungin? Capsofungin is a fungicidal agent, whereas fluconazole is a fungistatic drug. Fluconazole is a fungistatic drug and caspofungin is a fungicidal drug, but this caspofungin does not penetrate the vegetation, but is very not sure that whether it will penetrate into it. But this is more effective. Caspofungin is more effective than the other drugs. For sure, this amphotericin B does not penetrate the vegetations. Amphotericin B injection, it is an injective form. It is an injectable form. This will not penetrate the vegetations. So surgical eradication of the foci along with the antifungal measures to be taken. Most commonly used antifungal are amphotericin B, fluconazole, and third one is capsofungin, of which the fluconazole is a fungistatic and capsofungin is the fungicidal agent. Coming to the surgical management, what are the indications for surgical management? Of course, valvular lesion. We have to decide whether the valve can be repaired or to be replaced. Okay, this is the thing which we have to decide through echo before surgery itself. Okay, and infective endocarditis with the large vegetation and intracardiac abscess formation or any septic foci, you have to operate and you have to remove the vegetation. You have to remove the abscess cavity and you have to close the abscess cavity by some means, and in case of septic emboli, you have to remove the emboli also. This is the primary aim, followed by valvular repair or replacement if necessary. So there comes the rheumatic infective endocarditis. So about infective endocarditis, summing up of infective endocarditis, first you should know about the valvular anatomy and the causative organism, Duke's criteria of major, minor criteria, what are the investigations to be done for infective endocarditis, and the prophylaxis, antibiotic prophylaxis for infective endocarditis. Following this, we have to write about the drug therapy, that is medical antibiotic management for infective endocarditis, and medical management for fungal infective endocarditis, followed by surgical management. These are the topics which you have to write as an essay in case of infective endocarditis if asked. And of course, the investigation you have to write about the X-ray findings and echo findings also. Now coming up to the next essay, that is rheumatic heart disease. So rheumatic heart disease is a diffuse inflammatory disease. Okay, it is because of the inflammation. It is not because of the organism itself. It is because of the inflammatory process. Okay, this is delayed immune response to a group A beta hemolytic streptococci. Okay, the rheumatic fever is a diffuse inflammatory disease in response to a group A beta hemolytic streptococci. It is not because of the bacteria itself directly. Patient will have some sore throat. That is the most common symptom before surgery, before developing a rheumatic fever, sore throat or fever. So while collecting history for a case of RHD, we have to ask the history of sore throat and recurrent sore throat and fever in the younger age group. This will direct us towards the diagnosis of rheumatic heart disease. So this can affect, what are the structures which can be affected because of this delayed immune response are heart. Joints can be affected, CNS of course, and skin and subcutaneous tissues. And around 40 to 60% of patients will go on for developing RHD with ARF, that is acute renal failure. So as said before, it is a chronic condition. It is not an acute condition. It is a chronic condition because of the inflammatory response. The rheumatic heart disease is a chronic response. Rheumatic fever is an acute thing. Rheumatic heart disease, acute means it is also delayed response. Rheumatic fever is a delayed response to the infection, but it can be an acute also. But RHD is a chronic thing. Okay, the RHD involves all the layers of the heart. This rheumatic heart disease can cause pancarditis, that is epicardium, myocardium, and endocardium. This results in scarring and deformity of the heart valve. The inflammatory cells will result in the scarring of the myocardium, endocardium, and can affect the valvular lesions and cause scarring, and deformity of the valve can also occur, and all four valves can be affected, of which the most commonly involved is mitral valve. Next is the aortic valve. Okay, rheumatic heart disease, it involves all the three layers of heart, like epicardium, myocardium, endocardium. This results in pancarditis. This can cause scarring of the valve and deformity of the valve, and this can also affect all the four valves. Of all the four, the most commonly affected is mitral valve and the aortic valve. So this is about the introduction of the rheumatic heart disease in an essay. Okay, so coming to the incidence, the median age group of rheumatic heart disease, rheumatic fever, is 10 years. Although it can also occur in the adults, and it is more common. It is both equally common. It is both equally common in the male and the female. But in case of female, if the rheumatic heart disease affects a female, the prognosis is very poor than males. Okay, and it is more common among the poor socioeconomic status and in overcrowded area because of the recurrent cross infection of the bacteria. So it is more common in the poor socioeconomic and overcrowded area in the developing countries. This is about the incidence, and it is all full of values, like incidence of rheumatic fever in developing countries 27 to 100 per 1 lakh population in a year. And the rheumatic fever, it can vary from 0.2 to 0.75 for 1000 children in a year in a school going age group. So thing which you have to remember is that it is a disease of childhood, rheumatic fever, and it can be diagnosed at the age itself. Okay, the median age is 10 years, although it can occur in the adults also. In 20%, for example, in case of 100 people of rheumatic heart disease are there, 80% can be diagnosed in the childhood itself. 20% of people can present in the adult group. Okay, and it is equally present in the male and female, but in case of female, the prognosis of disease is little poor. So as said before, the etiology for rheumatic heart disease is the group A beta hemolytic streptococci, and because of this infection there is a delayed immune response. That is the main culprit. And because of this, there is a delayed immune response. This causes pancarditis. There is both epicardium, myocardium, endocardium is involved, and also causes scarring of the valve and deformity of the valve. Scarring and the deformity of valve occur, and this causes valvular lesions. This can further go on for a failure even because of the valvular lesions. So common risk factor for rheumatic heart disease are poor socioeconomic situation and overcrowding because of the cross infection is very high. Cross infection is very high, and around 80% of RHD patients are diagnosed in the childhood. Okay, that is age group of 5 to 15 years, and this cross infection and the sore throat are more common in case of rainy season, cold climate, and associated URI and previous history of rheumatic fever, and any genetic predisposition for valvular heart disease will aggravate the situation. So any genetic predisposition for valvular heart disease will aggravate this situation. So coming to the pathophysiology, as said before, the group A beta hemolytic streptococci infection can result in, if untreated, will release toxins and cause delayed immune response. This is represented by a fever episode that is called as rheumatic fever, and here all the layers of the heart are involved. All the layers of the heart are involved, resulting in pancarditis, and valve is also involved, and involvement of this valve can result in valvular regurgitation lesions, and this stenosis can also occur. Of this, all the 4 valves can be affected because of this. The most common is mitral valve, followed by aortic valve. This valvular lesions can result in heart failure as a final end stage. This is the natural course of the disease. And this is the pathophysiology, like immune response affecting the heart, resulting in vegetations. Myocardial Ascoff bodies are seen, and fibrinous pericarditis can occur. These are the pathological terms which you are supposed to know. Myocardial Ascoff bodies are seen, and the fibrinous pericarditis can occur. So here too, what are the clinical manifestations? Major manifestations are carditis, that is pancarditis, polyarthritis because of the joint involvement. Preferably, patient will have a small joint involvement, and chorea because of the CNS involvement, and erythema marginatum because of the skin involvement. Of course, subcutaneous nodule because of the subcutaneous involvement, subcutaneous tissue and skin involvement. These are the major manifestations of rheumatic heart fever. Of course, pancarditis, here you can see a normal pericardium is very thin, and the pericardial cavity is filled with fluid. There is 6 to 10 ml of pericardial fluid will be always present. In case of inflamed pericardium, it will get inflamed and thickened, and there will be adhesions to the thoracic surface also. So this is arthritis and the chorea. This is a CNS manifestation, and erythema marginatum is a dermatological manifestation of rheumatic fever and rheumatic heart disease, and subcutaneous nodules can occur. So coming to the minor manifestations of rheumatic heart disease or rheumatic fever are fever, malaise, weight loss, anorexia, and arthralgia is also be present. These comes under the minor manifestations. So, you will recollect the major manifestations here. The major manifestations are, first will be pancreatitis, arthritis, arthritis. In coming to the skin, it will be erythema marginatum, subcutaneous nodules. So, these are the manifestations of the major manifestations of the rheumatic fever. Okay. So, coming to the investigations and laboratory finding, and you have to go for a throat culture and sensitivity to demonstrate the causative organism, that is group A beta hemolytic streptococci, and of course, the acute phase reactants will be elevated like ESR, erythrocyte sedimentation rate, CRP, and patient will have a increased WBC, leukocytosis, in the total count. So, in ECG, what are the findings you can feel? There will be prolonged PR interval. There will be a prolonged PR interval. This is because of the delayed conduction. P wave is due to the atrial contraction and R wave is due to the ventricular contraction. So, the time taken for the impulse from the SA node, that is atrium to ventricle transmission, is being increased or prolonged. This delayed conduction of the this delayed conduction of the impulse will result in the prolonged PR interval in case of rheumatic heart disease. So, what are other investigation to do? Or diagnosis of RHD is based on this modified Jones criteria. Okay, for diagnosis of the modified Jones criteria is the most important thing which you have to know. This Duke criteria for infective endocarditis, Jones criteria for the rheumatic heart disease. So, we have seen about the major and minor criteria. So, what are the major criteria are? Again, we will recollect it. First thing will be pancreatitis, arthritis, chorea, erythema marginatum, and subcutaneous nodules. Of these five, if any two major criteria is present, then the patient is supposed to have rheumatic fever, and in case if there's only one is present, two other minor criteria are satisfied like fever, malaise, arthralgia, generalized weakness, PC fatigability is there, then it is considered to be rheumatic fever. So, these are the Jones criteria. These are the factors which are used to diagnose rheumatic fever. If two major criteria is present, patient is diagnosed to have rheumatic fever, or one major criteria with the two minor criteria, either or. Like present laboratory findings, as we already seen, the elevated acute phase reactant like ESR, CRP, leukocytosis, and ECG shows prolonged PR interval, and echo is used to diagnose the valvular pathology and presence of any vegetations or any abscess formation inside the heart, and X-ray is used to diagnose the cardiomegaly as a secondary response to the valvular lesion. And in pus culture, and sensitivity, there is evidence of growth of beta hemolytic streptococci. It is a first point to conclude or to infer patient is getting a rheumatic fever. A positive throat culture for this specific organism, and elevated anti-streptococcal antibody titer, that is ASO, anti-streptococcal titers. Okay, and the recent history of scarlet fever. These are all used for confirming the diagnosis of rheumatic fever. In X-ray, what are the things we are supposed to see are cardiomegaly. Second is the pulmonary congestion, And other findings related to the heart failures, like increased pulmonary plethora and increased bronchovascular markings in the lungs, and if in case there is a presence of stenotic lesion in the mitral valve, that may be in right ventricular hypertrophy. Okay, if there's a regurgitation lesion, that will be dilated right ventricles. Okay, these are the findings which are supposed to see in the echo or even in the chest X-ray. So this is how we will measure the cardiomegaly. So there will be a central midline will be drawn, and from the left, the maximum length will be taken as A. Towards the left of the heart, the maximum length will be taken as B. So this total length, this maximum length will be taken as C. So if A plus B is more than 50%, of C, then it is considered to be cardiomegaly. Adding this will be more than 50% of the C is considered to be a cardiomegaly. And here we can find this is an RV apex, that is right ventricular apex, which shows right ventricular hypertrophy. Okay, here you can find right atrium is also enlarged towards this side. Okay, and this is the aortic knuckle. There is now no evidence of any aortic valve involvement from the X-ray in this patient, in this X-ray. Okay, so this is the cardiomegaly, more than 50% of the widest area of the thorax. So coming to the echo, it is used to detect the valvular insufficiency. Echo in RHD is used to detect the valvular insufficiency. In case of in chronic situations, it is used to monitor the valvular status, whether we should go for a repair or a replacement, or when to operate. Okay, so this is an X-ray finding. You can see a regurgitative lesion over here. There's a regurgitation over here. Cardiac catheterization. Okay, this is not indicated in case of acute RHD. Acute RHD is not indicated because this can go for rupture, because this, in case of acute cases, there will be severe inflammation will be there. Okay, in case of chronic diseases, we can go for heart catheterization. Why it is done? It is a minimally interventional technique. It is an intervention technique. It is a minimally invasive. In case of mitral stenosis, we can go for balloon valvuloplasty or percutaneous transluminal commissurotomy, commonly done in mitral valve. So these are the minimally invasive procedure that can be done for mitral stenosis because of RHD or any reason, if the valve is fit for minimally invasive surgery after applying Wilkins scoring system. After applying Wilkins scoring system, Wilkins scoring system has 4 gradings based on the 4 criteria, like valve mobility, valve thickness, subvalvular fusion, chordae status, or rupture of the chordae or leaflets. So based on all these, and also calcification, this chordae rupture, if ruptured, you should go for replacement only. We have no other options. But in case of other criteria, we can go for repair also. So based on the Wilkins scoring, we can go for either cardiac catheterization and balloon valvuloplasty, or PTMC can be done for mitral stenosis. In case of mitral regurgitation, we can go for mitra clip. These 3 are the minimally invasive technique available for mitral valve lesions. Okay, But this cardiac catheterization should be done only in case of chronic RHD patients, not in case of acute rheumatic heart disease. That is the point to remember. Okay. So how it is done? So catheter is passed on from through the femoral artery, common femoral artery, into the aorta, into the left ventricle. So here in the mitral valve, we can go for balloon valvuloplasty. Like we can just, the mitral valve is very short, we will pass on the catheter and will inflate the balloon here. So the valve will get opened. Or we can go for a commissurotomy. We can just give a nick, or we can give a cut over the commissures so that the stenosis is relieved. So coming to the ECG in rheumatic heart disease, there will be a sinus tachycardia, which is the most frequently seen finding in the cases. In some cases, there may be a bradycardia because of the increased vagal tone, and sometimes patient can go for arrhythmias like atrial flutter, and multifocal atrial tachycardia can occur, where there may be multiple P wave, a saw-shaped P wave in case of atrial flutter, and multiple P wave in case of atrial tachycardia, and atrial fibrillation can also occur. This results in the dilatation of the atrium. Why atrium dilates in case of continuous or frequent atrial arrhythmias like atrial fibrillation? Because of atrial fibrillation, the atrium cannot completely contract and push the blood into the ventricles. So the left ventricle will have, the force of contraction will not be sufficient enough to push all the blood inside, but it will keep on receiving the blood from the pulmonary vein. This results in the dilatation of the atrium. So this is the ECG finding of sinus tachycardia. All P wave is present. So when P wave is there, it is considered to be a sinus tachycardia. Here you can see the atrial fibrillation. You can see P wave, P wave, P wave. Here one P wave, and there is nothing here. P wave. In case of atrial flutter, there will be sawtooth shape, like a sawtooth, even more sharper than this, like sawtooth will be there. This is a multifocal atrial tachycardia. You will have a multiple P wave of different morphology. P wave, multiple, each with different morphology. Of course, we should know the ECG also like a cardiologist. The sawtooth pattern is seen in the atrial flutter. This is normal thing, and this is the atrial fibrillation. Multiple P wave will be there, and one P wave is conducted to the ventricle and will have a QRS complex. So coming to the histological finding in the rheumatic heart disease, you will have a verrucous lesion in the line of closure, and histologically there will be Ascoff's bodies are present, and Anichkov cells are seen, and there will be a bread and butter appearance because of the fibrinous deposits in the pericardial cavity. So things to be noted in histological finding are, there will be a verrucous lesion, and Ascoff bodies will be seen, and Anichkov cells are seen. In case of pericardium, there will be a fibrinous deposits in the pericardial sac. This can go for constrictive pericarditis even. So these are the images of histological images of Ascoff bodies and Anichkov cells, and you can see the bread and butter pericarditis. This fibrinous strands are common and commonly seen in the pathological of rheumatic heart disease. So coming to the medical management of rheumatic heart disease, first thing will be eradication of the disease. So prophylactic therapy is indicated after rheumatic fever and acute rheumatic heart disease. So prophylactic antibiotic plays an important role after rheumatic fever or after an episode of acute rheumatic heart disease. So what to be started, when to be started, and the primary prophylaxis should be started as early as possible after the episode of rheumatic fever, or even during the rheumatic fever episode was diagnosed. What to be given? So penicillin G IM should be given every 4 weeks, or you can go for an injection of 0.6 to 1.2 million units of benzathine penicillin. Okay, so commonly what we give are tablet penicillin, phenoxymethyl penicillin, at the dose of 250 mg 1 BD. This can also be given. Even penicillin G can be given. Injectable drugs can be given in case of acute rheumatic fever for prophylaxis in a asymptomatic patient with no history of rheumatic fever in a near short time. You can go for a oral antibiotic like phenoxymethyl penicillin. So this should be given in the endemic areas, and patients with high risk needs this. Okay. So patients with rheumatic heart disease and valve damage requires a single dose of antibiotics. This is the like something similar to the infective endocarditis prophylaxis. The prophylactic antibiotics are must for all patients with rheumatic heart disease before any procedure is done. Usually 30 to 60 minutes before surgery, we are supposed to go with an prophylactic antibiotic. Patients who had rheumatic fever without valve damage but does not require any prophylaxis. If the patient has acute rheumatic fever but has no cardiac involvement, then there is no need for endocarditis prophylaxis. We should not use penicillin, ampicillin, namoxilin for a patient who had already received a penicillin, because patient may have antibiotic resistance. Okay, so you have to be very careful and very judicious in case of using an antibiotic. Okay, so drugs that can be used alternative to penicillin or clindamycin at the dose of 20 milligram per kg in children and 600 milligram in adults, or azithromycin 500 mg OD can be given. Even clarithromycin can also be given at the dose of 15 milligram per kg in children. Okay, so to maximize the cardiac output, what to be done in case of RHD? Of course, as we all know, RHD is a delayed inflammatory response to a infection by group A beta hemolytic streptococci. So to reduce the severity of the valvular damage or cardiac damage, we can go for corticosteroids to reduce the inflammation. And ACE inhibitors like enalapril, captopril, ramipril, this prevents the remodeling of heart, like patient developing a ventricular hypertrophy. And of course, beta blockers, this reduces the arrhythmias and reduces the load of the heart. This diuretics is used in the heart failure. This reduces the preload and stress over the heart. These are the drug therapy to increase the cardiac output. And salicylates can be given for arthritis, and of course bed rest can reduce the pain because of arthritis. Coming to the surgical management, it is indicated when there is a valve insufficiency. When there is a valve insufficiency, we are supposed to go with the surgical measures. This can be either as a in minimally invasive technique or as an open procedure. For mitral stenosis, in case of minimally invasive, we should go for balloon valvuloplasty or percutaneous transluminal mitral commissurotomy. In mitral reconstruction, you go for mitra clip. Open technique, we have only thing is that you can go for a mitral repair in case of mild to moderate stenosis or regurgitation lesion. In case of severe regurgitation and severe stenosis, you have no other option other than mitral valve replacement. The only contraindication for this minimally invasive procedure is acute rheumatic heart disease. During the acute episode, we should not go for cardiac catheterization. So this is the heart valve. Prior to commissurotomy, the effective orifice area has reduced very much. So, patient might have a mitral stenosis. If even this area is not closing up properly, this is the coaptation area. If it is not coapting properly with the opposite leaflet, the patient may have even mitral regurgitation, both in same patient. Okay, so this patient, after repairing, post commissurotomy is done. Commissure is opened here, and cut has been given here. Post commissurotomy, of course, the stenosis is relieved, and if the coaptation is proper and adequate, regurgitation lesion will also be relieved. So, for critical stenosis, emergency procedure like mitral valvulotomy or balloon valvuloplasty can be done as a minimally invasive technique, and mitral valve replacement can also be done by open technique. Of course, mitral valve replacement is also being done under minimally invasive cardiac surgery using a transaxillary approach or even a mini sternotomy approach, or sometimes you can go even with a left anterior thoracotomy approach of just 5 centimeter incision in the second or third intercostal space. This is a technique of balloon valvuloplasty. The catheter is introduced into the left atrium, and the catheter is traversed through the mitral valve, and the balloon is expanded inside the mitral valve so that the stenotic area is pushed away from each other and breaking the mitral valve calcifications. And this is the other image of balloon getting inflated in the stenotic mitral valve. This is called balloon valvuloplasty, and this is a mitral valve replacement done by the open technique, and this can also be done as a endovascular technique. And nowadays, the endovascular valve implantation is getting popular. The endovascular valve implantation is getting popular by just passing totally endovascular thing. It is done as a total endovascular thing. By passing the catheter through the femoral, you will reach the mitral valve. Will use a balloon to open up the stenotic area, previously stenotic area, to create a space for the new valve to be implanted, not replaced, but to get implanted. Okay. So, the second, again the catheter will be passed with the same guide wire, and the new mitral valve will be implanted in that region, not replaced in that region. So, this is endovascular valve implantation. This is an upcoming procedure. It is gaining some more familiarity on people now. So, this ends the end of the rheumatic heart disease